Let your wind blow over my garden. Let your wind blow over my garden. Away go north wind and come oh south. Let your wind blow over my garden. Smell the spices dancing in the air. Let your wind blow over my garden. Smell the spices dancing in the air. Let your wind blow over my garden. Closed is my garden. I found.
Morning, everybody, and welcome to the first official morning of the Rural Health Conference. Very exciting to be here to see so many new and old faces, and great privilege to be chairing the first session, introducing some very exciting speakers. For those of you who don't know me, I'm Kate Sherry. I'm currently the chair of Rural Rehab South Africa, and we are very proud to be co-hosts of this conference. It's always quite interesting when you're like, okay, so you're going to introduce me, and then I'm going to introduce them, and then you sort of wonder how many degrees of introduction one requires for a conference. But I am allowed to go straight on to the first speaker. We are very privileged to have Dr. Susan Levine here from UCT. You'll see the little blurb in the conference book. And you can read it yourself, but Susan is a leading light in medical anthropology. She is pioneering work with Steve Reed on medicine and the humanities, and she's asked me to mention two particular books that she's written. I happen to have read one of them, and I can tell you it's fantastic. The books are called Medicine and the Politics of Knowledge, and that was the one I read, and then Children of a Bitter Harvest, which is about child labour in Worcester. And you'll see from the blurb that Susan does a lot of work in determinants of health and social issues in the wineland specifically. And she's a recipient of an NRF award to examine pediatric illness from the perspectives of children, which is quite an unusual thing. And I think reading Susan's book, Medicine and the Politics of Knowledge, made me realize how really everything that we do is commissions, whether you're a doctor giving antibiotics or prescribing TB meds, a nurse following up on an HIV test. We base our work on assumptions about who people are, how they think about things, why they've come to you, what's going to happen when they go away, how are they going to interpret what you say. And I think particularly as a therapist, you often realize that you're missing a lot of the context that informs why the person is there and what they'll do with what you give them. So I've come to realize just how absolutely essential it is that we look at work of people like Susan and start taking similar approaches ourselves to really understand what we give rural communities. So without further ado, I would like to introduce Dr. Susan Levine.
Thank you. Good morning. Thank you. Can everyone hear me? All right. I would like to thank Professor Steve Reed, Doctor of Conradi, where are you? And to the entire group of people who've put this conference together. It's an absolute privilege and honor to be here, and I just enjoyed the presentations last night and talking with all of you. You're wondering, might wonder what a social anthropologist is doing here. I'm asking the same question, so I hope that we'll discover that together and that there'll be more points of contact than not. And also just to say, I've been reading through the work, papers, and really you are all, the word last night that was used was brave. And I think, so there's other words as well that we can add to that. So I'm looking forward to learning with you. So here's the paper. So thank you again. Part 1, the day. There are wine farms nearby this room where 105 steps or strides separates people living with bodily afflictions such as chronic hunger, tuberculosis, dental disease, and severe forms of depression from those with access to relatively healthy diets and access to a range of medical services for the illnesses that affect us all. I was absolutely encouraged to see that people who live on farms, farm workers, were on the list last night in the presentation around issues that need special attention. That's what I'm going to focus on for the first half of my talk. The close, even intimate proximity of radical health disparity underlies the peculiar coexistence of bodily comfort and discomfort on farms in the Western Cape, where rural, peri-urban, and urban life worlds collide. The anthropological work of Andrew Spiegel, who's in fact at UCT in the anthropology department, is instructive here in his work on deconstructing the spatial associations of rural life as distant, remote, and other. The rural, and by way of extension, rural health afflictions, are near, entangled, and part of an urban matrix of social relationships. Are you with me? Are you sure? Okay, good. The political geography of social life in South Africa is made up of what medical anthropologist João Biel, the great João Biel, calls zones of social abandonment. To work in these zones requires, as all of you know too well, a balance of empathy and detachment, as well as a responsibility to work against the historical weight of injustice and dehumanization. As the great cellular pathologist Rudolf Virchow, Steve and I both have have all of you, or any of you heard of Rudolf Virchow? Yes? Yeah, good. He's amazing. Wrote in 1848, quote, and this is one of my favorite quotes, which I quote everywhere I can, medicine is a social science, and politics is nothing else but medicine on a large scale. Medicine, as a social science, as the science of human beings, has the obligation to point out problems and to attempt their theoretical solution. The politician, the practical anthropologist, must find the means for their actual solution. In my own research on child labor in this region, the role of history has been an essential mode of analysis for understanding the deep structure of alcohol dependency and the prevalence of what was also referred to last night, fetal alcohol syndrome among farm workers. The great Welsh academic, novelist, and critic, if you haven't read, he's wonderful, Raymond Williams, coined the term structures of feeling, to characterize the lived experience or the quality of life at a particular time and place. How bodily experience and illness, as well as in health, are folded into these structures of feeling is the work of medical anthropology, which is what I do. And what I'm hoping for, and what I think all of us are hoping for, is some kind of connection between what ethnographers, philosophers, historians do in the field with people who are also patients, and what you do as practitioners at the coalface, at the front lines, who have the skills to actually treat. So what is it that can be shared? What is reciprocal? What are the points of connection? And I think they're deep, and I think they're unexplored, and within those is huge potential, massive potential. So again, it's just really exciting to be part of this. So the distinctive label for prenatal ethanol toxicity, fetal alcohol syndrome, which is now, you most know, now known as alcohol-related neurodevelopmental disorder, did not appear until the 1970s, despite centuries of anecdotal observations. The contemporary discipline of teratology, all of you know what teratology is, but for my anthropology students who don't, that is the knowledge of things that can cause abnormalities in utero. This emerged out of the 1950s epidemic of birth defects caused by thalidomide. FAS, which is caused by chronic pre- and antenatal maternal alcohol intake, is one of the leading causes of preventable mental and physical disability among infants worldwide, characterized by low birth weights, physical dysmorphology, most notably in the face and head, and developmental difficulties. As some of you know, right here where we sit in Worcester, Rawsonville, the Durans, the Boerland has the highest rates of fetal alcohol syndrome in the world. The most recent statistics on FAS in the Western Cape, reported by the National Institute of Alcoholism and Alcohol Abuse, show that 40.5 to 46.4% per 1,000 children are found by screening to be FAS positive. Compare this rate with a FAS frequency of 0.5 to 2.0 per 1,000 children in the United States, and the difference is staggering. In a 2005 study, Maternal Risk Factors for Fetal Alcohol Syndrome in the Western Cape, a control group and a case group of mothers of varying socioeconomic status were used to examine the factors that were associated with mothers having children with FAS. Consistent with the work of Professor Leslie London, who is a leading public health practitioner who examines fetal alcohol syndrome in this area, and also Pamela Scully, who is a contributing author to the now classic historiography, Liquor and Labor in the Cape. The study summarizes contemporary drinking patterns as a product of the DOP system. And for those of you from Brazil and otherwhere who, welcome, who don't know what the DOP system is, it's a historical, it dates way back in history, and it really is a kind of it is a remuneration using liquor as part of a wage. According to London, quote, alcohol dependence among farm workers continues to play a major role in enmeshing farm workers in a cycle of poverty and dependence from which escape is extremely difficult. These are some images, by the way, of, I'm trained as a documentary filmmaker, and when I started my PhD in this region in the early 1990s, I was, one of the ways that I had access to farms was I promised not to take any photographs or to make any films about children working or people drinking on farms. And so the deal was that I could hire a friend of mine who's an artist, and she painted portraits of, are these looping? Are they moving? Oh, good. That's fine. That's fine. That's Pammy. She passed away. Anyway, most of the people have. She's also died of tuberculosis. So that's another story we'll talk about now. So the relationship between liquor and labor can be traced back to the first large oceanic slave trade, spearheaded by the Dutch East India Company in 1658. In that year, Jan van Riebeeck established a new school for slave children who he recruited from Angola. His diary, which fascinatingly enough, his original diaries are here at the Klein Plassey Museum, just across the road. Not all of them, but many of them. And so I was able to read those diaries when I was doing my fieldwork here in 1996, 97, 98, and was able to have some of them translated, could read some of them, and they're there. So this passage I'm about to read to you was one that I found there in 1996 at the Klein Plassey Museum. His diary outlined the course of servitude that would alter the worlds of captive children. And this is the quote. 17th of April, 1658. This morning, beautiful, clear weather. We have begun to make preparations for the establishment of a school for the company's Angolan slave children from the Amersfoort. My apologies for my accent. School will be held in the morning and afternoon, teaching them correct Dutch language. To animate their lessons and to make them really hear the Christian prayers, each slave should be given a small glass of brandy and 2 inches of tobacco. A register must be established, and names should be given to those who do not have any names. Within a few days, these slaves will be brought under a proper sense of discipline and become decent people. Novelist Ben Okri, during his 2012 memorial lecture for Steve Biko at UCT, argued that recovering from such a colonial history in Africa, quote, is like a nightmare we wake up from after a struggle and a blink in stupefaction at the strangeness of daylight. With awakening, a great energy is freed. A new question is posed. The nightmare is over, but what do we do with the day? We do not have enough psychologists of history. Everyone seems to treat history as if our reaction to it should be logical. The people have emerged from a mutual nightmare. What should they do upon awakening? What should anyone do after a long trauma? What can anyone do? Okay, my note tells me now to have a sip of water. I'm going to do that. But I forgot I should have pre-opened the bottle. Ugh. I'm very allegiant to my script. Right. So, the clear lack of a shared vision of what to do with the day has led us in the post-apartheid years to the deepening of health disparity on farms. For despite the democratization of South Africa in 1994, which brought the agricultural sector within the ambit of legal protection, farm workers remain vulnerable to an undue burden of social and health problems. the high rates of fetal alcohol syndrome, tuberculosis, which has taken the lives of every woman you see in this series of images, and neurological disturbance due to the combination, this is critical here, the combination of alcohol and pesticide exposures are symptomatic of what medical anthropologists Paul Farmer, many of you will be familiar with Paul Farmer, and less familiar with the critical medical anthropologist Meryl Singer, call structural inequality or structural violence. When I say the deepening of health disparity now, right here in the Western Cape, we have seen an extraordinary deepening of hunger and illness in relationship to the consequences, the unintended consequences of the most recent strikes in 2013, where the minimum wage was raised from 69 Rand a day to 105 Rand a day, the consequence of which has meant that women on many of the farms have been retrenched, let go, not working. So that the way that the farmers have made up for the low wage increase to 105 is simply to reduce its staff by half. So Sana, I don't have a portrait of her here, unfortunately. So one of the young girls who I met in 1996, 11, whose life story I've been following ever since, I went to visit her about 3 months ago. I hadn't seen her for quite a while, about 9 months. And I was so horrified when I approached the farm. She walked towards me. I wanted to give her a copy of my book, of which she figures in extensively. And she was so thin, I thought she was dying. I mean, I thought she was really, I didn't know what to think. I could just see that she was ill. She's now 21 years old, and she was emaciated. And I said, Sana, what's happened? And she says, well, I haven't eaten for almost 2 months. I said, what's happening? She said she was fired after the strikes. And she had not been on strike. She didn't go on strike because she didn't want to lose her job. So on that particular farm there in Rawsonville, nobody went on strike because nobody wanted to lose their jobs. They were all threatened. But as a consequence of the wage increase, it didn't matter if she was on strike or not on strike. She still lost her job, and she doesn't have a husband or a boyfriend. Her father's passed away. She's got 2 children. And so there's a deepening of the feminization of poverty on farms with the wage increase. And this has led to very particular kinds of health trauma. She tried to take her own life last year, which I also didn't know about because of this retrenchment. Her father had worked on the same farm for 40 years. Her grandfather before that. There's an extraordinary, what do you call them, genealogist who lives in Rawsonville who has kept records of families who've grown up on farms together concurrently. Colored farm workers alongside. And so her genealogy goes back about 7 or 8 generations on this particular farm, has ended with her nearly dying of hunger with no land, no house, no savings, 2 children who are malnourished, who have no dental care. The services on farms in terms of tooth infection includes tooth extraction. I know a dentist who's just quit his job because he says he's not doing dentistry, he's just yanking teeth. Okay, sorry, I'm going off. I'm losing my script. All right, sorry. Right, one way that anthropologists have responded to Okri's question is to keep alive Virchow's vision of medicine. For more than a laboratory physician, he was an impassioned advocate for social and political reform. Section 27, as an activist organization, forcefully, as does TAC, of course, carries forward Virchow's vision. In his recent paper titled The Broken Thread, Primary Healthcare, Social Justice, I'm sure most of you read this, Care, Social Justice, and Dignity of the Health Worker, Mark Haywood argues that, quote, and this for 300 years, healthcare services had been planned and provided primarily to serve the white minority. Whilst there was an important medical tradition established through mission hospitals and by a small number of maverick white health professionals as a matter of policy, the health of black people was only a consideration if it affected labor supply or if infection posed a risk to white public health. But after the 1913 Land Act provided relatively limitless supply of black labor, the epidemics of silicosis, TB, and sexually transmitted disease were allowed to develop relatively unchecked, unquote. Van Riebeck's 1658 diary introduces for the first time the practice of using liquor to yoke child workers to structured regimens of work. In 1928, legislators called for an end to the DOP system, and in the 1960s, following the recommendation of the Milan Commission for Inquiry, it was eventually outlawed. But employers mostly ignored the law and continued to pay their workers with liquor well after the end of apartheid in 1994. As London argues, more than 60% of trauma cases presented at hospitals in the rural farming areas of the Western Cape are alcohol-related. In 1996, the health records at one farm school outside Rawsonville indicated that half of the children were afflicted with fetal alcohol syndrome as a consequence of adult alcohol consumption. The health records, which were compiled by the school's principal, also highlighted cases of head lice, skin irritations, poor nutrition, dental disease, TB, and other upper respiratory infections associated with lack of proper ventilation, indoor fires, and contact with pesticide sprays. The last risk factor for neurological damage is one that Leslie London, as I've mentioned earlier, has examined closely. London concentrated on the cumulative effects of pesticides in children who were also exposed to alcohol in utero, as well as the effects of alcoholism among adults who were exposed to pesticide sprays. We are looking here at the co-production of affliction, what Donna Goldstein calls, in her work on invisible harms, that is, invisible harms, toxic layering. So there are these invisible harms that we can name, which are layered. London found that alcohol increased the risks of acute and chronic effects of pesticide poisoning through mechanisms both social and physical. Children are especially vulnerable to pesticide poisoning due to their particular altitude or proximity to the ground, where shoes leave pesticide prints and toxic dust. Multiple and concurrent exposures to alcohol, pesticides, and malnutrition in utero and during the life cycle means that it is not possible to isolate FAS as the only cause of childhood stunting here in the Western Cape, where the rates among farming communities are twice as high as national averages for urban children. Thus, the spatial ecology of childhood, or children's distinctive ecological niche in the world, is filled with so much statistical noise that it is a puzzle to discern the origins or makeup of neurological disturbance. Rian was 12 years old when we met in 1996. He complained about pains in his legs. He said it gets very ugly in the winter from working in the poisonous dust. To ease his discomfort, he rubbed Vaseline on his legs to stop them from itching, but found it ineffective. He felt unable to ask his father for help and expressed his feelings of intense isolation. He said, "Drinking is killing my father." His mother, who's there somewhere, had died from TB when Rian was 7 years old. Even after his mother's death, Rian's father was partially remunerated with a bottle of wine each day, and when that was finished, he brewed his own beer in empty fertilizer bags left on farms. The point being here that children often endure certain forms of bodily discomfort quite alone. The tragedy is that on farms where farmers abide by the law that makes the DOP illegal, workers spend a significant percentage of their wage on alcohol. As described by Pamela Scully, laborers come to see the daily ritual of the tot as an immutable feature of their experience on the farm. Older workers in Rawsonville recall better times when they could drink, quote, for nothing. In short, without measures in place to combat alcohol dependency, the abolition of the DOP system has resulted in a terrible yet predictable social crisis, with in-uterine exposures and domestic violence the leading outcomes. Part 2, what to do with the day. In the second half of the talk, I focus on my more recent work in KZN, specifically on the relationship between poverty. We're really shifting gears here, but staying within somewhere in the same room at least. Specifically on the relationship between poverty and eye health. Have been hired by a consultant by Orbis, which is the leading NGO that tries to educate people about eye care by offering surgery for children with cataracts. Emerging from the data is a strong argument that private notes Emerging from the data is a strong argument that the insufficient ratio of doctors, nurses, and community health workers linked in community clinics is at the heart of eye disease, sight impairment, and blindness in poor communities. There is strong evidence that there is next to no support for people living eye afflictions in rural contexts among the poor, where eye drops are administered for a range of ocular discomforts, which could be remedied through surgery, eyeglasses, or further diagnostic interventions. A few quotes from the research. And the research was done at the Nkosi Albert Lutuli Hospital in Durban, and also in a number of outlying rural areas, including Ulundi. And I've been training young researchers to help with the study. It's a national study on the relationship between poverty and poor eyesight. And this is just some of the data that's coming in. Quote, "We're short of information," this is from Ulundi. Quote, "We're short of information here. It's not a regular thing that researchers like you come here to ask us questions about our life. One goes to the clinic and they won't tell you when there's a doctor coming. And the doctors aren't informative. They just dispense medicine. We can't get glasses. We're defeated before we begin because we don't have information." Another one, quote, "They don't usually show up. See, this optometrist at the clinic is only going to show up on the 16th of next month, and after that, we don't know. It could be another 3 months. The doctors aren't usually here for that kind of a thing." Many of the people I talked to about eyes said that doctors didn't seem to see their eyes as part of their body, that they were checked, but somehow the eyes were left out. This kept coming up, the eyes aren't really part of me. Quote, "I just wish the doctors would be more regular and available so I can get checked more often. I'm not the only one that needs it. I sometimes wake up with a thick web on my eyes and would have liked to have the chance to look into it easily. Tell me though, my friend's child has the same problem, but only on the one eye. What should I do with him?" What to do with the day. An insight I gained from field work was the extent to which success stories came not from medical outreach projects in communities or from a country that devotes enough resources, support, and training to its frontline healthcare workers, but from the sheer tenacity of particular individuals who navigate our nearly impenetrable referral system, an obstacle course of note. The question, Steve, you asked, stories of remarkable patients. Everyone I met in these clinics was remarkable for the tenacity that they managed to get to where they needed to be, to these specialist centers for their eyes. The following story from my field notes is instructive. Ijaj dug deep into her deep handbag and produced a bright yellow ear of corn, which she handed to Fikile. We three sat together in an unremarkable consulting room in the Nkosi Albert Lutuli Central Hospital in Durban. Ijaj had escorted Fikile to his follow-up appointment after he underwent surgery to remove cataract. Ijaj was 68 years old and Fikile age 9. He was a small frame boy, withdrawn and coping with flu. His right knee was bandaged from a soccer injury, but beyond that, Fikile appeared exceptionally tired. Formerly Fikile's neighbor, Ijaj, offered him a home after his mother died of an AIDS-related illness. They were both HIV positive. Ijaj was unemployed and self-reportedly extremely poor. She received an old age pension and disability grant, yet it took her more than a month to save enough money to pay for the 52-minute taxi ride from her home in Ilembe to the eye clinic in Durban. Fikile's father lived with his girlfriend in another village. He was also sick with an AIDS-related illness and unable to provide financial or interpersonal support for his son. Without extended family to care for him, Ijaj was determined that Fikile would not go blind from cataract, a condition which would irrevocably entrench the myriad layers of obstacles already in his young path. Leading up to the eye surgery, Ijaj maintained a rotating eating schedule for the other 6 people in her care, namely her children and grandchildren. The children in her home ate every other day until she had saved enough money for the journey. Such an unwelcome accommodation of poverty points to the social layering of disease and distress, to the inability to isolate medical conditions from the social and economic context in which they are lived, and the work that people undertake for one another. Last night, Worcester was called the care capital of the country. I wrote it on my cell phone, the care capital. And honestly, it's true in these spaces. The amount of care needed to get people to places of support is enormous. Though eye disease is considered a, quote, low impact condition in South Africa, for the afflicted who cannot see, it is a significant window to the world closed. To be on the other side, to see that window opened, as I've been privileged to do over the last 2 years working with pediatric blindness, to see a child in our work in Zambia, in Kitwe, is the most extraordinary practitioner who's taken it upon herself, not part of her job description, but she goes around to schools for the seeing impaired, all around Zambia. And she finds in almost every classroom, on every field trip, 3 or 4 children in each class who have cataract. She then manages to alert their parents. They're brought into the central hospital in Kitwe. They have surgery, and the next week they're in school for the seeing. It changes lives. So it is remarkable. There are, how am I doing for time? I have no idea.
You're doing well.
Okay. There are approximately 380,920 known blind people in the country, with a ratio of 6 ophthalmologists per million people here in South Africa. Since 2010, Orbis has worked to pilot, evaluate, and determine the most appropriate model for comprehensive child eye health in South Africa. With the exception of a 1952 essay written by Helen Keller about her momentous 1951 trip to South Africa, there are few analytic accounts of the social consequences of visual impairment in South African history. Keller's astonishing essay describes the uneven distribution of care for blind and deaf, colored, her words now, quote, colored, Bantu, and European children, and offers us a critical account of the impact of racism and class oppression on the disabled. She was just here, by the way, in 1951 at the Worcester School for the Blind. Not just here, she was here in 1951. She wrote, quote, all my life I had acted upon the conviction that humanity must be one. Each group is in a position to benefit the others by various means. Supported by these thoughts, I had had a measure of success in my work with the assistance of others. But how could I count with certainty on gratifying results in a country like South Africa, divided against itself? Unquote. More than 6 years have passed since Keller's visit, and notwithstanding the massive changes in healthcare legislation, the rollout of ARV treatment and state-subsidized medical facilities, screening for eye disease and access to quality eye care for the poor remains totally inadequate, with the burden of carrying on without sight falling on women whose seeing-abled partners continue to depend on their women for everything. In these very remote areas where we've been working, women actually have to put their hand to see if the oil is boiling to cook, to see how deep the water is in the pot, to navigate the furniture, to clean, while their seeing-abled partners are just expecting that these social roles of who looks after who don't shift or have to change in relationship to a dependency. Some of the women are now in their late 50s that we worked with, were given eyeglasses by us, and it's the first time they've actually realized they could see with glasses. So the research itself, the ethnographic work itself of going house to house and looking for certain kinds of afflictions is also a form of intervention, a very real form of intervention, and it's one that I'm hoping our students will take very seriously in anthropology, which is why we need the kinds of training that you have, and maybe this is a point of reciprocity. Keller's political commentary, while by no means a revelation today, offers a historical anchor with which to connect poverty, the delayed presentation of children with cataract, and childhood blindness. She was a maverick in her plight to raise public awareness about the impact of racism and class oppression on the seeing and hearing impaired. The performance last night was phenomenal. I really appreciated that. She believed that with adequate education and health care for people of all race groups, serious obstacles could be overcome. She also pointed to the lunacy of separate schools and facilities for children who could not recognize skin color as a marker of difference. She used the concept of blindness as a potent metaphor to condemn racial oppression and separate development. And if you haven't read this book, it's called Helen Keller Under African Skies. It is the most remarkable book. There's one copy in the archive in Cape Town in the library. It's a book about this big. It is a socialist, radical piece of writing about standing against racism, using blindness as a platform. Most extraordinary. So in the context of the research around eye care, because of the apparent lack of attention to eyes at the primary healthcare level, as well as sort of along the spectrum of referrals, many people consult traditional healers in KZN, and I was able to find a number of local remedies that treat eye afflictions. The one is scarification, the cutting, making little cuts in between the eyes and the putting in of powders. The other is through divining. The other is the use of cuttlefish. Traditional healers take the cuttlefish and they scrape it and they make it into a paste and then they put it on the eyes for cataract. The other is the translation from Zulu is feces of the moon. Feces of the moon. Anyone know what feces of the moon might be? It's a beautiful metaphor. Jellyfish. Beautiful. An extraordinary metaphor for jellyfish. Feces of the moon. So the jellyfish is put onto the eyes to remove cataract. There's also herbal tinctures. I couldn't find out what was used in the herbal tinctures. Many of the local traders at the market thought I might be wanting to patent them, which I don't. And prayer. So you have a number of people trying and looking for cure at the same time of not trying able to find cure. So now I'm going to say what to do with the day. So one of the ways forward through doing the research has been to implement new kinds of interventions. And the one is to begin training workshops with traditional healers in Durban and also in Zambia, where we're working in Kitwe. We need to develop excellent community radio. Most people listen to radio, so we have an organization called the Children's Radio Foundation here in Cape Town who are doing remarkable work with young people, doing radio stories about what cataracts looks like, what glaucoma looks like, how easy it is to fix with a treatment. I've recently helped to produce a film, which if I have time I'm going to show you, which is about two of the young girls that I worked with in Zambia. And we are now taking that film on the road with different health practitioners and facilitators to all schools, communities, clinics, and using the films. It's based on a project that I did in 2003 with Steps for the Future, which we made 35 films about HIV/AIDS, and we took them on the road in these traveling cinema mobile to Mozambique and Zambia and Zimbabwe and all through South Africa. And it's also a very powerful mode of communication. We also need, very critically, to develop a medical humanities that considers both the well-being of doctors and patients, where care for the caregivers is as important as care for the patients. We need to change the sea with which you practice, in which we practice, and bring these into conversation. This is happening in a very exciting way right now in South Africa and globally. We need new and innovative pedagogies for teaching the health sciences, and I can tell you that reading the program for this conference was so exciting because it's happening here, and it's very exciting. And it's the first time I actually have a chance to see what's going on in terms of pedagogical shifts. It's extraordinary. And finally, we need to be bold, as you are, and continue to see our academic and clinical work as contributing to social change and never become so task-oriented that we forget the bigger picture and power of our voices. We are poised here and now to carry on this work, to find the connection between our clinical, interpersonal, and political work. Waking up in South Africa is a cruel and magnificent gift. Okay, so that's it for the paper. All right. So that's going to close the video.
Good morning. We just have a question around the DOPE system.
Yes.
And the enforcement of the law against the DOPE system. It's something I encountered in the Northern Cape as well, very widespread in the farms there. You're working with the farms there. So I'm just wondering about how well it is enforced and whether there is really still very widespread practice.
Good question. It is enforced so that effectively no farmers in De Doorns, Worcester, Rawsonville, Slanghoek, that I know of, use alcohol as remuneration anymore. So it has been effectively enforced. The problem is that in the initial period of enforcement, sort of 1992, 93, 94, 95, and then all the way up to 2000, farmers, the front line of farmers who stopped using the DOP, also farmer workers began leaving in search of farmers who would give them remuneration in alcohol. So there was this period where farm workers who are alcohol dependent weren't earning enough to both have food and alcohol and electricity and the other daily needs. So there was a space where workers themselves were demanding the DOP. And so when I did a household analysis of wage usage on about 12 farms in the region, there was a shift. On farms where it was enforced, you had a much higher cash expenditure on liquor. You also had new entrepreneurs. So Rian, who was one of the young boys I worked with, in fact, the cohort of children I worked with in Rawsonville, when they were about 10 and 11, in the early mid-1990s, they all said, we're not going to step in our parents' footsteps, we're not going to drink. They made a commitment, we are not going to drink. And to my knowledge, none of that cohort are drinking. It's extraordinary. Sana is the one who's very hungry. She's lost her job, but she's sober. Rian, also sober, he has used his sobriety to create a kind of industry around selling liquor, just off farms, so that if people don't have transportation to get into the town to buy liquor, they can just buy it on the outskirts of the farm, and they usually inflate the price a little bit. So while the DOP system is illegal and it is being enforced, there are other ways. Alcoholism itself has not been tackled with in these areas, so there aren't programs. It's not being dealt with. Leslie London had a project called DOP Stop, which you may be familiar with, which was a traveling mobile clinic which visited farms and educated people about the DOPs, about not just the DOP system, but the effects of alcohol disease. And its funds were cut, and also it remained in Stellenbosch and Franschhoek area. It didn't come up into this region through the Huguenot Tunnel. So it has been enforced, but the impact of alcoholism has, as to my knowledge, not changed considerably, except among younger people. There's quite good education programs in schools, which is really very hopeful. So Sana and Rian and Cornelius and a number of the kids I work with have benefited from the kinds of education that's now happening in De Nova School, for example, in Rawsonville, where they have a very aggressive kind of attempt to talk about alcohol and alcohol addiction, which has ameliorated it to some extent. Though, okay, so I hope that's...
Great. Thank you.
Hello.
I'm Madeleine. Just a question, if you're aware of any interventions, not necessarily just in this area, but worldwide, for breaking or for having an impact on alcoholism once you've got a community where there is a lot of alcoholism. We have also in our areas, very poor areas where you have very high prevalence. Usually the poorer the areas, the higher the prevalence of the alcoholism. If you're aware of interventions that are actually effective, and education and information certainly helps partly with prevention, but if you have alcoholism education of its own, does it usually break the cycle?
Yeah, that's the question. I don't know of any, aside from DOP Stop, which I don't know how effective it was. I think it wasn't as effective as they'd hoped it would be, and it didn't grow as a program, as a project. In my own work, what I have seen is really through schools, through education. But it's been an interesting feature of my own research that the children that I worked with very closely since 1996 through to today, I'm still in contact with them as young adults, it has to do with, I think, the reason that so many of the children are not drinking, and this is not a feature of anthropology or the anthropological encounter, but there is something about attentive listening to people, to young people, over time and taking interest in them, in which gives them a sense of, I don't know, I think it's going to be through the personal relationships that are formed between young people and people who are listening and are advocating for their rights. That's where I don't know if any program can do it, but I do think a huge attention to individual people, to life stories, to autobiography, to biography, to those kinds of very personal engagements can make a huge difference down the line. And certainly farmers are living right there. I mean, when I say 105 steps, I'm not kidding. On the farms where I work, I've counted them out. I have walked between the farmers' homes where there is food in the fridge. Sana's depression, where she tried to commit suicide, was precipitated by the first experience that she had working inside the home of her employer. She'd never been inside, her family had been there for generations, she'd never been inside their home. But for a short time, I think the domestic worker who'd been working inside the house was sick or on leave, and so they said, Sana, would you like to come work here? And she said when the children came home from school, there was food for them. There were snacks after school. There was a change of clothing. There was hot water inside the house. She didn't realize that her experience 105 steps away, living in a place where it was cold, the floors were cement, they had these solar panels now put on top, but they weren't particularly effective. There was a sewage problem, so there was always sort of drainage problems. There's chronic hunger, people were dying of tuberculosis. She didn't I don't think she fully grasped the inequality and injustice of her children suffering compared to the children who were living inside the house until after that. So one way, of course, would be to work with people that are living close. The farmers are there in those environments where alcoholism is taking root. So certainly there should be some sort of social responsibility on the place of employers. That would be the closest starting point. But in terms of big projects and programs, I'm so sorry. We have it I'm actually South African. My accent betrays me. I was born in Cape Town. My parents went to exile when I was very small. So I grew up in California and I came back in my biography. In California as well, we have the same problems on farms with alcoholism. Yeah.
One question. Okay. My question relates to the ophthalmology part and our referral pathway that you studied. I think it's very nice in the video that a very polite response to, oh, you didn't go when I told you to go. But I think, having spoken to them, I doubt that's the response that most of them would get at that point. I wondered if there's been any work into trying to change the attitude of the referral hospital to patients who arrive on the wrong day, or who, when, as you mentioned, the financial outlay for them of just getting to that one-day appointment is, almost more than they can ask. Because, to my experience, the response is the person maybe misses the day, and already the hours spent getting the patient just to get that appointment has been possibly a few. Running back and forth, doctor, sorry, you can't speak to the doctor now, he's in surgery. Okay, phone back in 2 hours, things like that. So that the patient misses the appointment. Frustration is immense from the healthcare worker, and I really think that's a very idealized response that many patients won't get. But then even they get the great response, they get the rebooking, maybe they miss the day, there's some miscommunication, they arrive on the wrong day, and they get told, oh sorry, your appointment was actually yesterday, come back. I wondered if there's been any look at showing, doing a video clip on the actual pathway of a patient in that specific, out of your study, and showing that to the actual ophthalmologists, that they might even understand a bit better that, if they arrive on the wrong day, actually, this is what a patient has possibly had to do to get there. And maybe you can fit them in, I just wondered if maybe a natural place to show the video might actually be the referral service themselves, that they possibly understand the difficulties of the patients getting to them.
That's great. Thank you so much for the question. I've just written a paper called The Obstacle Course, which is coming out this week in the Anthropology. It's a journal. It's called Anthropology Southern Africa, which does exactly that. And it traces 5 patients through the referral system over a period of 2 or 3 years. And it could be that it's a great idea to maybe we could. This film was based on just research with the 2 young girls I worked with, and the paper is a much broader look at this obstacle course, is the metaphor I've used. And we are planning on making a series of films, so that would be a great idea to trace that out in a visual form. It's a great idea.
To the referral center themselves.
No, absolutely. I think, yeah, that's next on the cards. So part of my work, I was trained as a filmmaker, and part of my interest in film is that it's a clear tool to use in these kinds of contexts. So great to come see me, and we'll write it up. You can write the script.
Thanks very much, Susan. I'm
Thank
sorry
you
we
so much.
don't have more time for questions, because I think we could probably spend the whole morning talking about this stuff. But yeah, incredibly powerful. Thank you very much. And I think it's often difficult for us to even see these things, because you think, I can deal with the queue in my OPD, but what about what's going out there? And I think what the humanities offers us, and particularly anthropology, is a way of looking at those things, a language to speak about them. And I loved the phrases that you borrowed from you, the toxic layering and all. It makes so much sense. And I think often as health professionals, we don't have those words. We don't have ways to write about it or speak about it. And I think the partnership between medicine and the humanities and other healthcare professionals as well is enormously exciting. And I liked our last, sorry, I don't know your name, but the question about, what would happen if we as healthcare workers saw that stuff, heard those stories, and yeah, I think it opens up some enormously exciting possibilities. So thank you very much.
Thank you. Thank you so much.
I'd just like to introduce our next speaker. We were asked as Rudasa to nominate a keynote speaker from the rehab and disability side of things, and we were very excited that Jean Elphick agreed to come and speak to us. And having listened to Susan's talk, I think it's a lovely follow-on, because Jean, for me, is somebody who has taken on the question of what do we do with the day when the nightmare is over. And as therapists, we don't always work in the realm of so the child had an eye problem, but if you get him to the clinic and he has an operation, it's going to be better. We often work in the realm of, there is no answer, it's not going to be better. You came to the hospital, you hoped for help, but what you've got is me, and let's see what I can do with that. And Jean began her career as a concert physiotherapist at Mount Lady Hospital. That's when I first got to know her, and she arrived thinking, why? But I've got to do my concert, I might as well do it somewhere cool. And by the end of the year, she was a passionate convert to working with children with disabilities in particular. And coming from a physio background, which is very sort of curative and not curative, sorry physios, but very much, let's look at the physical problem, let's deal with what's there and try and make things better. And Jean started looking wider, and she decided that this wasn't the platform to address the problems that she saw as the biggest ones. And she's gone from being a new graduate convinced she was going to do sports physio at the Sports Science Institute in Cape Town to the manager and creator of an enormously exciting and successful program working with the mothers of children with disabilities in Orange Farm outside Joburg. And she will hopefully tell you more about the process, but she's brought this group of women to the point where they are going to their local clinic and saying, excuse me, you can't treat children with autism like this when they mess up your waiting room. Going to the Department of Education and going, why aren't there schools for our children? And these women are doing really, really incredible stuff. And to see someone who came from a physio, this is what I do background, who's taken the question of what to do with the day and taken it to that level is enormously exciting. So, welcome to Jean. Thank you very much for coming to speak to us. And for providing us sort of a practical, okay, so what next? What do we do with this information? I have to tell you, while she's busy setting up her program, that Jean did her master's research on the program that her master's research was investigating how to set up a program she wanted to set up. And she knew that the sexual abuse of children with disabilities was absolutely rife. So she did her master's dissertation in Orange Farm looking at the experiences and the rates of sexual abuse of children with disabilities. The quote that came through was, it's just a matter of time. And when Jean was really reaching the end of her emotional capacity, having heard all these stories, she went to a psychologist who specialized in trauma counseling. The trauma counselor was in tears listening to what she was saying. And uncovering that level of pain can be a very difficult thing to then wake up from and carry on with. So, are you ready? Go, well done.
firstly, I'm extremely terrified to be here. I have quite serious imposter syndrome because not only do I not really work specifically in healthcare anymore at all, but also I live in Johannesburg, which is not rural. However, I think that the work that I do now and the things that I'm interested in is 100% inspired, and it came from the time that I spent and the people that I met working at Madweleni. So I will do my best to share with you a little bit of the journey that I've been through and what I've specifically been doing for the past 4 years. And hopefully what I'd really like is if there are some more universal takeaway messages that you might be able to glean from the talk. And also, I think at some point all of us become a little bit bored of describing the problems and actually want to try and look for a solution. And that's what I've really been trying to do. And now what I'm in the process of is actually trying to measure that solution and measure whether in any way it might have any kind of impact. So I think mostly anyone that really gets into the healthcare sector has a desire to try and help people and to try and make things better. And it took me quite a while to translate and to connect the fact that really what I was trying to do more than help people as a physio was for people to be accessing some kind of justice. And the situation that I was encountering time and again and banging my head against was an injustice, total social injustice. And so when I first started, it was actually always Kate that would be talking about like policy and the bigger picture, and I was like, I can't even find the key to a room where I can work. Like, I don't know where to start. And I found it extremely, extremely difficult, especially as a young therapist going to a place where there was hardly anything in place. And I can see Dr. Richard, who in May of the first year that I was at Madweleni and couldn't get off the kitchen floor because I was in tears, sent me home to my parents and told me only to come back when I'd stopped crying. But it's only become, actually, strangely, it was only in the last year or two that I actually started to connect the situation with human rights and started to articulate the types of things that I was seeing in terms of human rights, and started to realize that really what I was seeing were not just, our unlucky things, but actual human rights violations. And so if you'll indulge me, what I'm going to focus on is my real area of interest, and that is children with disabilities and the way that they interact with a huge amount of multi-layered legislation which should be there to help them, but actually, in reality, doesn't really. Can I have some of your water? Okay, and the reason I became interested in children with disabilities is it really seemed like they were the most slated, had the rawest deal. And many things that I have learned subsequently have been quite startling to me. For instance, when I was at Madweleni, I didn't even consider trying to get children into school. I mean, it wasn't even like on the cards. It wasn't even, within touching distance. But the fact of the matter is that in South Africa, we have, our constitution is heralded as being one of the most enabling in the world. We have very pro-disability legislation. For instance, in the very first section of our constitution, equality, disability is specifically mentioned as a grounds that you may not unfairly discriminate against someone on. But I'm just going to give you a quick couple of ideas of some of the other rights that are violated almost systematically. For instance, everyone has a right to basic education. That comes directly from our Constitution. However, we're not exactly sure how many, but there are at least 500,000 children in South Africa that have disabilities, that have never been to school, and probably will never go to school. And although it's compulsory for children between 7 and 15 to go to school and to be accessing the general education and training part of the education system, it's extremely difficult. And when you have a child that's 16, that's never been to school, they should have access to adult education. But unfortunately, it's almost impossible to get a child into a school. And I'll give you, it is absolutely an obstacle course. So some of the research that we've done in a township outside Johannesburg is the average of the cohort that we looked at was mothers went on average to 8 different schools to try and find a place that would take their children. And they also spent an average of 680 Rand on the transport going back and forth to try and make that happen. However, 91% of those caregivers were single, unemployed mothers. The next major area that Kate mentioned was sexual abuse and violence. And of course, although we all have the right to live free from violence and to be safe from abuse and degradation and live with dignity, the fact of the matter is that children with disabilities in a country which has been dubbed the rape capital of the world are the softest targets, especially children that can't express themselves verbally in a straightforward way, and also children that have an intellectual impairment. So the Medical Research Council brought a paper out in 2009 that said that they'd found that about a quarter of South African men have raped, and almost half of those have raped more than once. Also, almost half of reported rape cases in South Africa are children, and 40% of those are children under the age of 12. So children with disabilities are really an absolute sitting duck. And this newspaper article is from something that came out of the Northern Cape last week, and a girl that was actually going to a training centre or a special school went home and told her mum that something had happened and she'd been raped. And after reporting it to the school, she returned to the school and was raped a further 4 times. And even though she can understand and talk, she has been dubbed as not fit to testify, and the case has pretty much been dropped. So the other thing is that once you do bring a case, trying to get that case through court is extremely difficult. And in 4 years, I've only managed to get 1 case to actually go to court. And although it was a really brutal rape, the perpetrator walked away with a 5-year suspended sentence, meaning that if he doesn't do anything in the next 5 years, if he's a naughty, then he's free to go. And finally, this is where you guys fit in, I would hope, is that although our Constitution has a slight caveat on the access to healthcare for everybody, children do have the right to basic healthcare. And I think a lot of Dr. Levine's talk really gave a clearer idea of the sort of real the obstacle course that entails. So as a quite discontent healthcare practitioner, I really started to wonder that as one person with hundreds of thousands of people in your sort of catchment area, what was possible for me to do that would actually influence these grave situations and create some sort of justice. And So after doing a baseline study for an organization called Africa Tikkun in 2010, and going to 6 townships around South Africa, most of them around Johannesburg and 2 here in Cape Town, and really spending as much time as possible speaking especially to the caregivers of children with disabilities, and finding out really how they were articulating their situations, but also finding out from them their priorities for change. I then went to go and do my master's, and with a little bit of creative manipulation, managed to make the dissertation not a literature review or anything, but actually an action plan, not for research, but for an intervention. And what the intervention is based upon is community-based rehabilitation, which is something that's always spoken about and put out there, but there are actually so few really well-documented implementation of this kind of program. And certainly for the empowerment component of CBR, which is really the sort of most modern conceptualization of CBR, there's almost very, very few working examples to go on. So CBR is basically the WHO endorsed strategy for promoting human rights for people with disabilities in resource-poor settings. And it's developed since the 60s from initially the first component, which is really the health component, which in a nutshell comprised of training kind of community members to almost be pseudo-therapists and go house to house and find clients and provide them with some sort of support and some sort of advice and connect them with a healthcare service. Over the years, it's kind of evolved, and the empowerment component, although it is a cross-cutting theme, is quite new as a standalone component. And so I built an action plan and then somehow convinced this NGO to let me give it a try and to try and actually implement it. And so what I've been implementing for the past 3 years is a program called the Empowerment Program, Children with Disabilities and Their Families. So in a nutshell, really what the point of the program is to catalyze civic action and to mobilize mostly caregivers of children with disabilities who act as proxy agents and advocates for their children with disabilities, to support each other, access resources and opportunities, and campaign for social change, especially with people or services or systems actively exclude them and unfairly discriminate against them. So the program has 4 main kind of areas of work, and what I'd like to do, if you'll indulge me, is to give you an example of what has actually happened. One example from each of these components. So the first thing that sort of has evolved is a self-help group. And the self-help group is a bunch of women, mostly. There are about 3 men that sometimes come. But it is a self-help group that meets every week. They have a room at the community center within the township where they can meet. And through quite a long series of development together, they've chosen their own name. They've chosen that they want to have purple as their color, so they have purple t-shirts. More recently, they have delineated some tasks, some roles and responsibilities within the group. So they now have someone that's in charge of organizing Christmas party, and someone that's in charge of running the second-hand shop that they've started, and someone who's the chairperson. And they have, they really were given very sort of slow but comprehensive training on how to run their own organization. And within the next year, this group, which has called themselves Sitingutando, would like to register themselves as their own organization and continue to function as a peer-led and autonomous body at the moment we have no financial support from the NGO, but on their own. The next thing is that for each and every client that comes in, not all of them participate actively in the self-help group, but we also provide a sort of an obstacle course demystifier. And that is a coordination of referrals and follow-up when referrals fail. So in Orange Farm, for instance, we now have over 230 files open. And at last, I've been able to employ 2 of the mothers to run that office. So this is Maria, and there she is working with the file. And so what we try to do on a case-by-case basis is not just look at the health needs of the client, but also look at whether they need help with accessing a care dependency grant, whether they have any one of a sort of whole spectrum of needs. And more recently, there have even been things that we've been asked to help with, for instance, illegal occupation of somebody's house. For instance, a mother's child was sick. She spent quite a lot of time at Barra. When she got home, she found that her house had been sold by someone else to a new family that was living in her home. So assisting her with those kind of total needs, which really do support the child. The next sort of component was really engaging these self-help group members especially in becoming advocates for themselves, but also in conducting research which is extremely useful as an advocacy tool to describe what the situation is and to, that sort of legitimizes the cause really. But also, we do a huge amount of teaching on different aspects of human rights. So when the program really first started, before there was a self-help group or anything, we basically went from extension to extension in the township and publicized or promoted a one-day sort of launch event. And at that event, we tried to say, look, this is our idea, but I was the only staff member. There's only so much that can be done. Basically, this really depends on each and every one of the caregivers. And then immediately we offered a 12-session or 12-week course, a very comprehensive adult learning course on human rights as related to disability. And not only looking at what the legislation says, but actually relating that directly to their own situations, and also delineating the process required to actually access those rights. So it's no use you telling me, oh, your child has a right to be in school and to get an education, without actually saying, okay, well, in order to get that, first you need this assessment, then you need a diagnosis, then you need to go to the educational psychologist and you need to get an LSEN number. And then only then can you go and apply at this kind of school. There's been quite a progression. So you can't really see her in this picture, but this was the first class of caregivers that graduated from the first Human Rights and Disability course. And this lady in the corner here, she's looking down, but I've now been able to employ her and another mother to teach, and they teach human rights and the disability courses, as well as a whole bunch of other topics like disability and sexuality. And here you can see Pindile in the self-help group setting, And she's doing this first lesson of the Human Rights and Disabilities course. And on each of those papers is written one of the Constitution's sections, you know, the different articles of the Constitution. And she's trying to get from everybody which are the ones that they would really like to learn about the most. And so this is somebody that initially went through the course themselves, was continuously involved, and is now actually employed full-time to teach others and spread the word in a way that's way more appropriate and on point in terms of language and translation than I'm capable of doing. So in addition to teaching, these self-help group members have also taken up any possible opportunity to speak in public. And so to date, I mean, they've spoken in front of thousands of people. They've spoken at the Constitutional Court. They've spoken in front of 800 students, first-year students at UJ. So they've really become quite skilled at public speaking and sharing their story. I'd just like to share a quick anecdote as well. Is that last week I went to go, they arranged that I had to be at a clinic at 7 in the morning on a Monday morning, because a few months ago one of the mothers went to the clinic and because she was worried that her child might have TB. And so her 4-year-old son is on the autistic spectrum and she had to wait in queue, and he was causing chaos and throwing tantrums. And she really started feeling worse and worse about herself as all the other clients waiting in the queues were, you know, tut-tutting about what a bad mother she was. And eventually, Banele opened a tap somewhere in the clinic, and one of the nurses just lost it at him and screamed at him in front of everybody, and then also screamed at her. And so after she got her man to, they left, and she came to the self-help group. And every week, part of the agenda is for people to, after singing, and then after praying, and then after introducing everyone, if there's anyone new, is a section called Good News and Bad News. And she stood up and shared this as part of the bad news. And so there was a little bit of toing and froing, a little bit of conversation, and some of the other mothers decided that, no, this is... One said, you know, oh, well, maybe you should try a different clinic. But eventually their consensus was that they were going to go back to the clinic as a group. So about 5 of them went back to the same clinic on the Monday and went to go and see the matron. And it was quite astounding that the matron not only called in that same nurse and she got a personal apology, but she also said that if any of our group members came wearing their purple t-shirts, that they would be able to jump the queue with their kids. And she also invited them to come and do awareness about autism spectrum disorder. So that wasn't enough for them. So they went on a roadshow to all 5 clinics in Orange Farm and did the same. And then they also got me to go, they'd organized a whole box of pamphlets from the Autism South Africa, which I had to go and fetch and bring to them. And they proceeded at each clinic on a different morning. They had to start early to speak in front of the people sitting in the queues, share their stories, explain to them their experiences of having a child with a disability, answer questions. I mean, it was quite amazing. And they also found quite a couple of new clients while they were at it. And yeah, so that would be an example of undertaking a project in something that was actually meaningful to them and something that they wanted to tackle as a priority. So the Sidingatando Self-Help Group, as a group, their mission is as follows, and this is in their words. Our mission is to support each other and to become leaders in understanding our children with disabilities and fighting for their rights, especially the rights to equality, education, and safety. So they have specifically focused on those 3 sections of the Constitution that they really want to push. And we want to do this by supporting each other and teaching our community to understand and accept our children. And so I think you can see by that little example at the clinic of how they've gone about doing that. And I was just so struck, I mean, this was last Monday, at the fact that not only had they done this completely on their own, with no transport money or no sort of logistical arrangement from myself, but also I really believe that what they actually did was way more effective than anything I could have planned or tried to do myself. And I do think it was way more meaningful as well. So I'd like to share with you just an example of one of the projects that we've undertaken, one of the big projects that fits into quality educational safety. And I'd like to do this because I'd like to encourage you to stop trying, or not to stop trying, but to consider how much more powerful that your message could be to change things and make an influence if you are not only fighting as an individual, but if the people that you're trying to help are actually fighting for themselves. So these mothers were absolutely adamant that they wanted their children to access their right to an education. And so that was where we started. So the first thing that we did was we realized that the more people that we could find, the better we could show how many children in Orange Farm weren't going to school, the stronger our case would be. So the self-help group mothers started recruiting and finding other people who had children with disabilities, or who had children that were struggling in school and were not coping in school. And so when they started that campaign, we had 60 files open. And within a few months, we had over 170 files that were open at that point. For each of the files that were opened, we were able to capture a whole lot of information and capture that onto a database. And that database is now administrated by 2 of the mothers that work in the office. And in addition to just collecting the information, we also started to figure out what was the process, what was the obstacle course. So to make a shortcut in the obstacle course, we realized what the requisite documentation was in order to go on to the next step with the Department of Education. So we would not refer anyone on until they had all the documents that they needed to take to the educational psychologists and the district-based support team. And then we started making and following up on referrals, and following up meaning sending the same 40 people and then 60 people and same referrals over and over in lists. So eventually what I'd do is I'd just take screenshots of the database and send them to the sort of head of Gauteng Department of Education. We also started engaging on a case-by-case basis public interest attorneys, especially where there were critical sort of easy things that we could troubleshoot. For instance, a child that has been given an acceptance letter to the school on condition they produce a study permit, because they don't have South African citizenship, but the child has an asylum, so that therefore nullifies the need for, and so the child needs to be accepted into the school. We also, I sort of orchestrated and helped a lot to get the caregivers from the self-help group to have audience with increasingly more influential people. So, we really started with going to the different ward councillors, but then the next step was to see the mayor and go to Parliament and speak in as many places as they could to try and raise awareness of the problem. And eventually the Department of Basic Education, the Gauteng Department of Education, called us and to a meeting And the outcome of that was to set up a task team for children in Orange Farm with educational support needs. And we worked very closely with them to put together a submission stating what the problem was and the fact that we needed a school. And so in September last year, we finally had, after like a really long process, a meeting in Orange Farm. And there is a guy from Gauteng Department of Education holding up the submission that had been signed by the MEC of Education, and letting us know that a school for 600 children would be built in Orange Farm at a cost of construction of over 256 million rand, which is over 200 times the annual budget of this program. And that will be a state-run school which is sustainable and that should be there long term. So up until then, really I had I was really trying to sell an idea that I didn't know would work, if it would work or not. And so that was really one of the first things that was like, actually really, if you do stand together with a united voice, and if you do consistently try, that real change is possible. And so as that is in the sort of budget processes, they've already opened 4 classrooms of 25 kids each in abandoned classrooms in an existing school. And I've heard that from next year, they're actually going to move us into a whole school and take a whole lot more children. So that, of course, was a huge triumph. And then... Now our mission is to actually get that to really happen in real life. We're only really halfway. Okay, so just very quickly, the sort of final part of my talk was just to show that, I'm going to skip that, was to understand a little bit more about empowerment, and that's really what I'm looking into now and trying to articulate and trying to understand more about how this small, very modest program is in some way contributing towards individual level empowerment. Because it's all very well and good to say, oh, they're so empowered. But actually, how do you really capture that and understand it better? And so in addition to understanding empowerment as a sort of combination of agency, which might either be kind of expressed directly, as this mother is standing up for herself and saying something, or through a proxy. So, for instance, any of the referral letters or anything coming through the advice and referral office would be using the organization to act as a proxy agent. And then finally, empowered behavior, and that as collective agency. So that really looks towards the empowered behavior of people standing together and speaking with a collective voice. And further to that, what I've been having a look at with the members of the self-help group are 3 dimensions of empowerment. So firstly, interpersonal empowerment, the way that they feel about their power to influence the situation for their child. The second is interactional empowerment. So in a nutshell, do they know where to go, who to speak to, and what to ask for? Do they know how to influence those that are more powerful than themselves, like you guys? And finally, empowered behavior. What are they actually doing? And I'm going to skip ahead a little bit because I've only got 5 minutes left. But in addition to using qualitative methodologies like focus groups and case studies and so on, myself and 7 of the self-help group members have we have developed a questionnaire to try and capture the sort of different levels of empowerment. And so we did quite a lot of work to get from this to this to this to this, and then finally to our final questionnaire. And what we've done is, in those three different dimensions, we've used a series of 4 pictures, which shows someone. At the top you can see someone that doesn't feel very powerful inside about their power to influence their situation, to someone that's really feels proud and powerful. In the second row, you'll see someone that really is doesn't know what to do, and that goes right through to someone that's she's got a brain, she's got knowledge, and she's got papers, and she's actually able to give advice to others and share information with others. And in the bottom ones, the first picture is called "Sitting and Waiting for Government." And right on the far side is advocating for children with disabilities more broadly, not just advocating for the children of the people in the self-help group, but more broadly for children with disabilities in South Africa and beyond. And this I'm in the process of really trying to analyze, but I'd like to just share some preliminary findings. We took a cohort of 2 groups of 33 people. The one group were people who had either attended a self-help group once or never, and the others, but they do have files open on the program. And the others were people that more regularly attended the self-help group, including the 7 co-researchers that helped to develop the questionnaire. They then conducted the questionnaires through doing an interview with caregivers. And just very quickly, on all 3 dimensions, there was a statistically significant increase in empowerment of those that were participating in the self-help group. There was also a 4th dimension that we added, which was a subjective overall score, which each co-researcher gave to the person that they were interviewing. And that was also a statistically significant increase. And it was also accompanied with some quotations and so on. So some of them were quite scathing about the individuals that hadn't been participating. So the one was like, she's clueless, she has no idea what's going on with her child, she's really struggling, she's recently lost her husband, these kinds of things. And then some of them were really funny for those that were. The one was like, she is so powerful now, she say, I'm the boss. And so, yeah, it's quite difficult to put across and to capture these sort of outcomes. But it has been extremely interesting for me, and something that has been really quite fun, although stressful. And so, yeah, I think if anyone's interested in talking to me more, please don't hesitate to come and have a chat. And thank you very much for indulging me.
Thank you so much, Jean. We've apparently got time for questions, which is fantastic. But now you know what she looks like, so you can also color.
Yeah.
Questions?
Don't all rush at once.
Jean, I'm just so impressed and so pleased that you could come and do this plenary, because I think you set the tone for the Waking Day. Really, congratulations.
Thank
it
you.
is absolutely outstanding. As an old veteran of CBR, I can see this light now. The dawn has dawned.
Thank you. So nice.
Ian Cooper, Center for Rural Health. Thanks very much for that. I want to make a comment that kind of links to what Susan was talking about. So the kind of thing you've described, which is incredibly important, and I think many of us are doing, which is the starfish kind of work. I'm sure everyone knows the starfish story. But the bigger picture that both of you paint is that across the country there's so much to be done, and we can get so overwhelmed with that. And one of the big things that has to be done is to get government to live up to its responsibility. And yes, we need to empower communities. My question is, how do we empower each other? And how do we empower the people coming after us? And in Rudasa, we talk about advocacy, need for advocacy. And yes, we have to speak to government, but we've also got to give ourselves and our students the tools to actually do the kind of thing you're doing all over the place. So Susan quoted Virchow. One of Virchow's other comments is that the physicians are natural attorneys of the poor. And how, as health professionals, do we all become natural attorneys of the poor? Many of you know the Lancet Commission report on health professionals education, which says 21st century medical education, health professionals education, needs to be addressing and training people to be change agents. So that's my question, is how do we influence in all our programs that our students come out and are change agents, are equipped to make a difference in every community, in every health service, in every clinic, in every hospital, to change the system and not just their patients.
Yeah, I think it's a very good question, and it's actually something that we were talking about last night. Because often, in my experience, these kind of more soft programs are left to those least experienced and those newest in the game. And actually, in order to be able to legitimately shift responsibility off yourself as the health professional, to do advocacy to the people, to change from being advocacy on behalf of to being self-advocacy for us. There's no quick fix. There's no easy way to just do it. And also it's quite difficult to find, certainly in literature, good examples of how people have tried to do that. So I think it's quite important to pay attention to real examples of and the sort of trying and successes and failures of those that actually have tried to do that and tried to engage. And the other thing that I'd just like to add is that I think, certainly for myself, going out into a rural setting, I really felt like it was my responsibility to change everything. And that is extremely stressful and really unsustainable. It's not something that as your first job that really is good for your mental health. So I think there needs to be a balance between providing good quality clinical services and in parallel empowering the sort of broader community within which and setting within which you're working. And I think it's quite a difficult thing to teach, I think. Yeah.
I must say, something I always take from talking to Jean is, oh my goodness, it can be done. And it is being done, but what I see every time is that it's taken her 3 years full-time and overtime to make this happen. And how often do we say, oh, we'll start a support group or a self-help group, or people must be empowered, they must know about their rights. And how many of us as health professionals, we don't want to hear anything more about the patient rights, because the way that people are not taught to use them in a way that's appropriate and really empowering, as opposed to just a tool to kind of throw at people. So I think what Jean's really shown us is the level of skill and care and the amount of time that needs to go into it. And it's very exciting, like you say, to see an example of it happening.
Yeah. I think also, it's important not to just think that there's no problems. Obviously, in a year's time, I should have completely withdrawn from Orange Farm, and only time will tell whether the whole thing will fall flat. I don't know at this point. But yeah.
But you do know you're getting somewhere when your group goes, oh, I'm so glad we have Jean, she's got a car.
Yeah, I know. I'm literally a glorified taxi driver.
I'm going to great pleasure of being able to go. We had Susan speaking about these problems from an anthropological lens and introducing us to looking bigger. Then we had Jean going, okay, how did she decide what to do with the day and take it from being somebody in a hospital to addressing those issues? And now we have Amelia Mfiki from TAC. You'll be familiar with TAC, but it's one of our finest examples of people really getting together and empowering themselves and standing up for their rights. And Amelia is the TAC Capacity Building Officer at the TAC Training Advocacy and Research Centre, and she represents TAC at the Community Health Worker Forum. We're very happy to have her today, just to speak to us briefly about things that are going on with them. I can just, do you have a presentation? Okay, can you just speak? Sure. Okay. Thanks very much, Amelia.
Good morning, everyone. My name is Amelia Mfiki, as introduced. The Capacity Building Officer for TAC in the Western Cape, but I'll be presenting about the key campaigns that TAC is doing and the focus of the organization at national level, including the challenges that we're facing as the communities. But if I can start with appreciating the time that I'm given to present the work that TAC is doing in the provinces and at the ground level. Now, the mission of TAC is to empower, mobilize, and advocate for campaign for people living with HIV-related mental health and make sure that we have access to prevention, treatment, care, and support. We have key achievements as TAC. One of them that we're always happy with is Adherence Club. We've started the Adherence Club in the Western Cape, in Kailicha in 2007 with Medicines Sans Frontiers. Now it's rolled out throughout the provinces, according to my understanding. But again, we have high numbers of condom distribution, given the challenges that we have on teenage pregnancy, HIV infection, and all of that. We've been distributing condoms, 1 million condoms a year in the Western Cape, and we started to introduce the same program in the province, in other provinces as well. When you distribute condoms, you distribute them door to doors to make sure that you educate homes and different families about the correct use of condom usage, and make sure that we refer those who have problems, because we're doing our program mostly informal settlement where people do not go to the clinics. So we make sure that we trace those defaulters or people who want to go to the clinic and refer them to the clinic. I also want to talk about one of the achievements of integrating TB and HIV, as I know that I'm talking to healthcare workers. It's one of the things that TAC is happy with. But if I can come to our key challenges that we're battling with at the moment, we have a problem with retention in care. As you may know, that most people start treatment and they drop any time when they want. It means that our community mobilization is still needed in the ground. We still have 40% of people that are dropping out on treatment after 3 years, according to Dr. Mutwaleti, the Minister of Health. We have a problem with a stock out. A stock out is a problem in the country. Particularly, there are provinces that are just having healthcare system collapsing, like Free State. I understand that we have provinces like the Western Cape that have minor problems of stock out, but there are a few clinics that will say, I don't have medication. We don't have your medication, then the client will be sent home. Then we are saying, if those are the problems, our program in the progress against HIV is at risk, meaning we still need to do more in terms of monitoring and making sure that whoever is relevant to account for medication, access to medication, people have their treatment on time. We are saying we need to keep the struggle of AIDS alive so that our people will have access to treatment. If I may share, I see few people that we've been working with in the program. If I may say, in the PMTCT program, as much as we have now, there's announcement that option B plus is an option for up from next year, and Western Cape has already started. We have a problem with pregnancy and alcohol. And now the information is, the evidence is saying you can drink and take your medication. You can take your alcohol with medication. of which the problem for us is disadvantaged areas where you know that if you're getting paid on Friday, you go to the shipping, you're coming back with no money, and then you are drunk, you forgot your medication. As much as it's the message that we need to send out, it's really challenging for us, and it's tricky, because people, when you say drink, they don't drink just a glass. They'll take a case of beers, and that's become a problem for us. But again, we are also saying that, we are also seeing the change in terms of the communities, and people now knows what is important about taking treatment. But the key challenge now is funding. We have a serious problem with funding. Our program, as much as we have condom distribution and testing outreach, HCT outreach, we have a problem with funding. Some of our programs, we feel that now we need to call for donations to different people, and we are calling for individuals to donate to take so that our work can continue. We started to do the program in TB in prison, where we say whoever went to prison need to be screened at admission so that we eliminate the risk of infections in prison, because these people go to prison and come back to our communities, then that spreads the TB in our communities. I have 0 minutes. Now, with my last minute, I want to say we have challenges of crime in our communities. If some of you may know that we have a doctor who was hijacked and killed in Kailita, Dr. Alogu. He was on the night shift, he was hijacked and killed. We started to do the campaign to say we condemn the killing of doctors, we need different people with skills in our communities, and we will support the human resource plan from the Department of Health. Thank you. We call for donation.